Hey everybody, we're going to start talking about cardiac emergencies here. So chapter 20, make sure that you are up to date on all of your cardiac A&P. If you need a refresher, go back to your A&P chapter, look over the cardiology, and obviously there's a brief overview at the beginning of this chapter as well, but obviously important to be up to date on that before we get into the emergencies here. So we'll quickly go through some of the cardiac anatomy and physiology, but this really should be review for you. So again, just make sure you're up to date on that. What you should know is obviously the composition of the blood, how the blood flows through the heart, through different chambers, past different valves, how the order it goes from arteries to arterioles to capillaries, granules, and veins. And then know the circuit between the heart, the body, and the lungs, where everything goes and when. You need to know all those things. The heart's job, obviously, is to pump blood. That's its only job. We know that it conducts its own electrical impulses in order to actually beat. So know about the electrical system in the heart. And then obviously, just like all other parts of the body, requires constant supply of oxygen and nutrients. Here's a quick overview of the heart there and its arteries. You see the main aorta there, then the aortic arch coming out of the left ventricle. We also see the left coronary artery, which supplies, you guessed it, the left side of the heart with blood. And we see the right coronary artery, which obviously supplies the right side of the heart with blood. And then we've got a couple of specific arteries that come off of the left coronary artery. We've got the circumflex artery, which wraps around to the backside of the left ventricle, and then the left anterior descending artery there that provides a large portion of the blood and oxygen, nutrients, etc., to the left ventricle. This is a particularly bad one to get occluded, to be blocked up. Sometimes they refer to heart attacks that occur here in the LAD, the left anterior descending as the widowmaker. So it's pretty significant. We'll talk about that in a little bit too. All right. First thing that we're going to talk about is called acute coronary syndrome. Sometimes it's referred to as ACS or cardiac compromise. This is any time at all that the heart is not getting its oxygen supply like it should. So anytime, for whatever reason, that somebody's heart is not getting the blood supply to the cells, it's interrupted for some reason, it's blocked, it's called acute coronary syndrome. We know that cells, they die if they don't have enough oxygen. And so obviously that's pretty important. More cells die here in the heart because of the lack of oxygen, less muscle that's able to pump that blood around. So obviously not a good condition. We have with acute coronary syndrome, whenever the heart cells get hypoxic, right, get low on oxygen, it's called ischemia. Ischemia just means basically that there's a reduced supply of blood and therefore a reduced supply of oxygen to the heart muscle cells. And again, they die quickly without oxygen, without that adequate blood supply with the oxygen and the nutrients. So when somebody is experiencing ACS, oftentimes they'll feel some sort of discomfort in the chest. That's the most recognizable and best known symptom. It can be described as pain, as pressure, squeezing, an ache, a dull ache as well. It can radiate as well. It doesn't just stay in the chest. It can go up to the jaw, through the neck. Can go down either arm or it can stay in the upper abdomen. There's also uh, symptoms that are less common, and we'll talk about those as well. But the most common symptoms here: pain, pressure, squeezing, a dull ache, or radiates up into the jaw, and both arms. You can stay in the abdomen there as well. Dyspnea, that trouble breathing, it's a common finding for older patients and in women. Also, what we should put in here is diabetics as well. They also can present with these atypical symptoms that are not quite typical. So we can find that trouble breathing might be the only symptom that their real symptom that their chief complaint is about. So we can have that kind of pain between the shoulder blades, epigastric pain, which is basically pain at the top of your abdomen there, things like that. And so we have to be aware that there's symptoms that certain folks can feel. So older patients, women, diabetics, as well, they can all feel these atypical symptoms. So we'll have to keep an eye out for that. Anytime that we suspect somebody is feeling symptoms that are atypical, then we need to keep in mind that this could be cardiac in nature, and until we rule it out, we should consider it to be cardiac in nature. Some other signs and symptoms that we could see with somebody experiencing ACS: nausea, vomiting is not uncommon, especially the nausea part. A lot of times people can get sick. Now, it doesn't mean that they won't throw up, just means that nausea is more common than them actually throwing up. People can pass out. It's called a syncope when somebody passes out or faints. So they can have a syncopal episode. They can be profusely sweating and suddenly. So they can be real diaphoretic. Their pulse can be abnormal, either tachy or brady. They may have abnormal blood pressures. A lot of time we'll see hypertension here. So some of that. And then we can feel some real anxiety and something that's called impending doom. This is where the patient will tell you, like, I'm going to die. I feel like I'm going to die. Like things aren't going well. I think I'm going to die. That's an actual symptom, and we should treat it as such. So if you're a patient who's experiencing ACS, some acute coronary syndrome, something going on in the chest, right? Getting all these symptoms going on, and they tell you, I feel like I'm going to die. Well, you should believe them, and work with that as a symptom. And so if anything, that should raise your antenna that something serious is going on here. And we should have a high index of suspicion that something big is going on here if your patient is telling you that. Obviously, context matters. If you got a patient that has stubbed their toe or something, and they're like, well, I think I'm going to die. Well, yeah, maybe not so much. But if you do have somebody experiencing these sets of symptoms and they tell you that, then yeah, let's keep that in mind. We should probably, again, have a high index of suspicion already. So this could affect our priority. How quickly are we transporting to the hospital? Is this a load and go patient, or should they stay and play? That kind of thing. If we get that feeling of impending doom, then we should be loading and going. Let's believe them, and let's get on the road to definitive care and do what we can while we're transporting. All right. For the assessment, obviously with every single patient, we're going to start with our primary assessment, and then making sure our mental status is good, that we know the chief complaint, that we take care of all of our ABCs, make sure there's no life threats there, and then we assign priorities. And then we'll explore that chief complaint a little bit. We're going to talk with this patient using our set of questions in OPQRST. to explore what's going on right now with this illness, and then we can get explore a little bit, do our detective work with some sample as well to try to figure out, paint ourselves the best possible picture of what's going on with this patient. Then we'll take our baseline vital signs. After this, then it's going to be our treatments. This is just all of our assessments that we've talked about before, and then we'll get to our treatments after we get our baseline vital signs there. Again, signs and symptoms, we've just talked about this. Pain, pressure, discomfort in the chest, neck, jaw, maybe the arms, upper abdomen, right? That epigastric pain in the upper abdomen. Maybe there's atypical symptoms, again, the dyspnea, discomfort between the shoulder blades, things like that. Palpitations, and it's palpitations, not palpations, palpitations. These are like skipped beats. Patients will feel extra or missed beats in their with their heart rate. A lot of times they can feel this. Sometimes just palpitations on their own make people a little short of breath. So if they're feeling that, that could be what's causing that difficulty breathing there, things like that. It may not be what's causing difficulty breathing. It can be something else, but it can be a cause. Again, sudden onset of sweating, profusely sweating, really diaphoretic, that nausea, and sometimes vomiting. Again, the syncope, anxiety, unusual generalized weakness. That means that somebody is feeling tired and weak all over. And usually what that is a sign that we're not getting enough oxygen out to the body. And so our cells aren't making enough energy, that kind of stuff. So that could point to a problem with the pump itself, right? There is a problem with the heart, probably. This person is really tired. They're really weak all over. Again, that could be a sign we're not getting oxygen pumped around real well here. We got to check to see if they got a normal pulse, right? Is it in the right range? Hopefully it's regular there. And then we'll be checking out the blood pressure as well. When we're taking a look at our patient, one of the most obvious signs of chest pain and all that kind of stuff is them clutching their chest, right? That's Levin's sign, right? So they're grabbing or clutching at their chest. Again, sweating. And then we can get some pale or going towards grayish skin, and then the anxiety and the restlessness. I think if you just think about it for a second, if you were yourself going through a situation like this, you'd probably be pretty anxious and restless there. Especially if you're combining all these symptoms, and 911 has been called and all that kind of stuff. So you got strangers in your house, and an ambulance there on your street. Neighbors are probably looking out their windows, right? All that kind of stuff leads to like the anxiety, the restlessness. So that's to be expected. That's real normal. All right, so in our physical examination, we're going to look for some things. We're going to try to figure out if we've got any pulmonary edema going on. Obviously, that can be a sign of heart problems there. And we'll look for that by listening to lung sounds. Maybe we can hear some rails going on inside there, right? That snap, crackle, pop, that air moving through the fine fluid. It's really fine and thinner fluid that's down there in the alveoli. We'll look for pedal edema, right? So swelling down in the feet and ankles. We can always take a look for the medical or jewelry saying, hey, you've got heart problems here. Maybe they're saying they've got CHF or anything like that, or that they take nitroglycerin, or it just says cardiac problems, right? And when we're doing this, one of the things we'll always do with somebody that's got any of these symptoms that we've been talking about here for acute coronary syndrome, right? Again, just to reiterate, acute coronary syndrome, anytime the heart is not receiving the oxygen supply that it should, right? It's for some reason the blood is blocked or whatever it might be from getting to the heart and perfusing it properly. So anytime somebody's got those ACS symptoms, we're going to give them a 12-lead EKG. You probably want to do this anytime that somebody's got breathing issues as well, just to rule out, as we've seen here, cardiac problems can cause respiratory problems. So anytime we have any of these ACS symptoms or just kind of respiratory symptoms, we're going to want to set up a 12 lead EKG. Now, what this is going to do is it's going to give, since we're not going to be, we can set it up and we can run it and we can send it to the hospital, but we can't interpret it. That's not something that we're going to learn. We're not going to learn how to interpret ECGs or EKGs. There, same thing. That's a skill for advanced certifications there. But we can take them and send them to the hospital so the doctors and nurses there can interpret it. So it gives us 12 lead EKGs, give us basically different pictures of the heart as it's beating, and it can tell us if it's beating well or not, what the electrical activity is in the heart. And looking at those little crazy scribbly lines on EKG can tell us where in the heart problems are. It's a fascinating technology. For those of you that are going to get advanced certifications or move on to nursing or medical school, when you learn how to read these, like, it's really cool. It's really cool. Not always easy, but it is very, very cool. So what we'll be able to do is we'll be able to put the stickers on somebody all over their chest. I'm sure you've seen it on TV shows and things like that. And we'll learn how to do it in class. But we'll put the stickers on and we'll run the 12 lead EKG, the monitor that's in the ambulances. We'll take these snapshots, these different snapshots of the heart, see how it's operating there. And then luckily, most of our units around here in our area, they are set up to automatically transmit EKGs to our closest receiving hospitals. And so all you got to do is get the patient set up, hit the 12 lead button, and then the monitor takes care of the rest. It takes the 12 lead EKG and then it sends it to the hospital for that. We don't have to worry about any interpretation beyond literally reading what it says. And we'll get into that in class. The monitor will give us its best interpretation there, and it could say that this patient is having a myocardial infarction, right? Basically a heart attack, an AMI, acute myocardial infarction. So beyond just reading what it says, we don't have to worry about anything there, and we'll talk about that when we learn how to put these on in class. In order to put some of this stuff on, we'll go over it quickly again. Like I said, we'll do this in class. We're going to put the stickers on their chest. The stickers, those are called electrodes. And just like the pads for CPR, right? We need good contact with the skin here. We need to get clothing and jewelry out of the way, so it's got to be good skin contact there. Whenever we do this, we're going to take a towel and kind of wipe down any sweat off of the chest, clear that up, and we can kind of rub just a little bit vigorously on the areas where we are putting these to remove dead skin cells. This is going to give us a much clearer picture on the EKG doing that. It really helps. Obviously, just like we learned about in CPR, that those pads don't really work well if somebody has got a really hairy chest. Same deal here. The electrodes, they're not going to stick well to the skin if somebody's got a really hairy chest, and so we may have to take some of that hair off. Your ambulance should be outfitted with a razor in the life pack kit, the monitor kit there. It should be fitted with a razor, so just in case we do need to shave somebody, we can do it real quick to be able to get a really good high quality EKG off of that ECG. There's basically 4 steps here to put these on. It's probably not going to make much sense right now looking at it, but there's 2 different sets of leads. The leads are the wires, and at the ends of the wires we have the little sticker, the electrode. We're going to place limb leads first, and so that's 1 on each leg, 1 on each arm. and then we're going to place V1 through V6 after that. Those just signify, for our understanding here, those are signifying different places where we're putting them, and in the end, these give us different pictures of the heart. These different leads, the V1 through V6. Okay, trying not to get too complicated out there. So essentially, what we're doing is we're placing 10 stickers on the patient. Here you can see a picture where limb leads go. They are marked. The little wire at the end, the little button that snaps onto the sticker, the electrode, they're marked, and it'll say RA for right arm, LA for left arm, right? RL and LL for the legs down there as well. Now, this is normal placement. However, there are other spots for normal placement as well. And let me just get this here. So what we can do in our area here, the protocols are put the limb leads up here on the shoulders, right arm, left arm, and a lot of times down here on the hips as well for right leg and left leg. Still getting the same, still getting a picture there. It's just a different way of doing it, but either way works great. Right, and here we can see placement of V1 through V6. These are the stickers here. So on the upper, the patient's upper right chest there. Let me see if I can do this. Okay, here we go. This is V1, V2, V3, V4, V5, and over here is V6. Okay, so they go in those specific places, kind of like that little sweeping, sweeps down here like this and around the chest, like that over towards the flank. So those are the places that we're going to put them there. And like I said, we'll have lab days to figure how to do that, where to put them, things like that. We'll learn those, some hands-on skills. All right, so what about the patient care for this person? Well, let's get them in the ambulance and let's put them in a position of comfort. More often than not, they're going to be semi-fowlers with this patient. We got to determine if oxygen and ventilation is necessary. That should say ventilation as well. If somebody is in respiratory failure, you recognize that they're having agonal breaths, agonal respirations, right? That gasping is like the last ditch effort of the body to get air in. Or if they're apneic, right, not breathing at all, they should get high concentration O2 via ventilation, right? So BVM, this patient. Now for oxygen, we want them to be between this patient, this acute coronary syndrome patient, between 94 and 99%. That's where we want to keep them. If they're very low, if their oxygen saturation is very low, right, let's say below 90, then we'll give it with a non-rebreather. If it's above that, above 90, but below 94, you may want to try out like maybe 6 liters on a nasal cannula, something like that. Now, you could go either way, but you're going to have to titrate it to effect. So if you start them off on a non-rebreather and get them up real quick, and it's heading towards 100, then maybe you back that off and put them on a nasal cannula and see if you can maintain them, between that 94 and 99%. If they're 94% or above, you don't need to give them oxygen. Right? You can, and there's no signs of distress. There's no significant distress with their breathing. You don't have to worry about giving them oxygen if they're 94 or above. If you are giving them oxygen, our goal is to get them to 94%, but no higher than 99. All right, so we got oxygen, maybe ventilations going on with this patient as part of our care. We'll do the EKG, the ECG, and then send that off to the hospital. Again, we can interpret it, they'll interpret it there. Then we give our aspirin. We know, hopefully we should know our contraindications for giving aspirin, the correct dose, the correct route, all that kind of stuff, right? So let's make sure that you're solid on your contraindications, right? We just finished up pharmacology a couple chapters ago. Those should be recent there. So you should know those pretty well. Then we're going to administer our nitroglycerin after this. We know what the indications and contraindications are, right? You gotta have chest pain. They have to have been prescribed this before, and they have to have it with them. And obviously, we need to know the contraindications there. That systolic blood pressure is good. Our area for the UT is 124 class. It is 100. Okay, I think we've said that a number of times. The patient has not had any ED drugs in the past 48 to 72 hours, and that we get obviously permission. After giving one dose, we can repeat in 5 minutes if everything is good. The patient's still not meeting any of the contraindications, namely the systolic blood pressure. Right, some of those contraindications aren't going to change after you give it the first time. Like if the guy hasn't taken any ED drugs, then you don't have to ask that again. And, it's not like you took some between when you asked them the last time and 5 minutes later. So we'll give another dose if there's not complete relief. All right. So usually nationally, there's the max dose of 3 doses, and in our area here, we're titrating this to effect. We're titrating the nitroglycerin to effect. So as long as our patient isn't meeting contraindications, we're going to give this to them until there's a complete relief, a complete cessation of symptoms. There, I feel like I didn't say that correctly, but we're going to give that again. We're going to give that medication until the symptoms are gone. After giving any dose of nitroglycerin, obviously we're going to reassess our patient. We're going to check in with their chief complaint. We're going to redo vital signs before we give that second or any subsequent doses. Now, here's the important thing: if we're giving doses of nitroglycerin, we have to be prepared for that person's blood pressure to fall below 100 there. So we're going to need to start treating for shock. The EMT level, it's pretty basic. We're going to lay them down. We're going to give them high concentration oxygen. We're going to cover them up with a blanket. We're going to keep them warm, and then we're going to transport as quickly as possible there. All right, let's talk about some cardiovascular disorders, some problems that we're going to come across in the field that people have with their hearts. So let's talk about those real quick. All right, so cardiovascular disorders are problems with the heart that are going to affect either the heart itself or structures within the heart like valves and blood vessels, either like the coronary arteries that surround it or blood vessels leading to it as well. So it's a number of conditions that can cause these things. Let's talk about coronary artery disease. This is a condition that narrows or blocks the arteries to the heart. A lot of times this is the result of a buildup of fatty deposits on the inner walls of the arteries, particularly the coronary arteries. The buildup there, those fatty deposits, as we've drawn in class a lot of times, things like that, it narrows the blood vessel, right? It basically, it's constricting how much blood can flow through there past that little blockage. It narrows the diameter of there. So we're not getting as much blood flow through there. So if we're not getting as much blood through there, we are not delivering as much oxygen to those cells, the nutrients, and we're not taking away as much waste products as we'd like to as well. So who's at risk for this? Well, a lot of it is genetics, so heredity, like, is it in your family? How old you are. Kids don't get this. This is, you have to have lived a life and eaten many cheeseburgers, etc. Right? It's not, you just don't get this with kids. High blood pressure leads to coronary artery disease, obesity, a lack of exercise, bad cholesterol, high cholesterol numbers there. Cigarette smoking also leads to this as well. Obviously, if we have if we're sticking with this for a minute, obviously, if we have the arteries of the heart, the coronary arteries, narrowed, and the heart muscle is not getting enough oxygen, then we're going to see all the symptoms here of ACS, the acute coronary syndrome. So, the chest pain, the discomfort, sweating, the nausea, vomiting, generalized weakness, feelings of impending doom, all that kind of stuff. So this coronary artery disease can cause acute coronary syndrome. Angina or angina pectoris, you can pronounce it either way is correct. It's chest pain that's caused by having not enough oxygen getting to the heart muscle cells, right? So the myocardium there, the muscle tissue of the heart. It's typically due to the narrowing of the arteries there, because of coronary artery disease. And a lot of times this pain that they're experiencing, the kind of pain, pressure, that kind of thing, they're going to feel this during times when the heart is forced to work more. And so if the heart is working more, its oxygen demand is higher. And if it needs more oxygen because it's working more, and those arteries are blocked somewhat, they're narrowed because of fatty buildup and everything, then that's going to cause a low supply of oxygen to those heart muscle cells that are now working harder. So that means when somebody's exercising, when they're exerting themselves, if they're working hard with their muscles, we can get this angina, this chest pain there. People that experience this are often prescribed nitroglycerin. So if their patient, as we've talked, if they have nitroglycerin, it tells us that they have a cardiac history. And one of the things that it tells us is part of that history is that they experience chest pain. A lot of times, let's go back to this right here. A lot of times with angina, during these periods of exertion or stress, we get the pain. But if they stop, if they relax, if they're not doing that workload, if they let their heart slow down and relax, sorry, that's my oven beeping. If they slow down and relax for a little bit, then usually after 5, 10, 15 minutes or so, that chest pain dissipates and it goes away. And usually that's a good indicator that it's just angina here that they're experiencing, and not something a little bit worse like a acute myocardial infarction, a heart attack. So we know what nitroglycerin does, right? It dilates the blood vessels. It's a vasodilator, and it relaxes. One thing it does is it eases the workload because it drops the pressure. It eases the workload on the heart. And it also dilates the blood vessels, and that's where a little bit more blood is going to be flowing past that obstruction. And so those cells that are causing the pain because they don't have enough oxygen and nutrients and they take away waste products, they're better able to be perfused after we take this nitroglycerin. Again, rest and nitroglycerin, both things that can relieve the patient of angina. if the symptoms, like we said, if they subside with rest, 5, 10, 15 minutes, it's angina, right? Um, uh, Now, if we get there and they're experiencing chest pain, right, we need to assume that it's a myocardial infarction until otherwise. Myocardial infarction, in layman's terms, is a heart attack. And that's what it's called there. Myocardial infarction. That means the myocardium is the heart muscle, and to be infarcted, it's ischemic. The heart cells are hypoxic and they're dying at this point. There, so that's the heart attack, the AMI, the acute myocardial infarction, or the MI, myocardial infarction. We have to assume that that's what's going on until proven otherwise. And so if they're resting with us while we're there, if we're giving this nitroglycerin, or just if it subsides with rest, then it's that. But we have to, until proven otherwise, we have to assume that this is the heart attack there. So we'll do all the things that we're supposed to: our primary assessment, good secondary assessment, OPQRST to get the history of what's going on right now, the present illness, some sample detective work to figure out what's going on in the past, how it relates to right now, and past medical history. And then we'll give ventilations if needed, oxygen if needed, the aspirin first, nitroglycerin if they have it. Get that 12 lead that gets transmitted to the hospital, and then get them to the hospital and definitive care quickly. It's pretty simple when you think about it, the treatments here. So, but that's what they are at the EMT level. All right, let's talk about the acute myocardial infarction here. All right, so an acute myocardial infarction. This is the heart attack. The short answer here, what is it? It is, for some reason, the heart cells are not getting oxygen, and so they start to die. And so the more heart cells die, the less the muscle in the heart is able to properly squeeze and pump. And so then we get a loss of blood flow to other parts of the body, the rest of the body, that isn't getting perfused as well, which again can cause death. So that enough of the heart cells die, well, then the heart can stop working properly, obviously, and then that patient dies. And that's how a heart attack will get somebody. So there's a couple of reasons for why that blood flow could be interrupted. So the plaque and the buildups inside the blood vessel, if it hardens enough, what can happen is there can be an aneurysm, and that's the bursting of a blood vessel. So if a blood vessel bursts, everything downstream that's supposed to be getting that blood isn't getting it, right? Obviously, because the blood vessel has burst, right? The pipe broke. So everything downstream of that isn't getting the oxygen that it needs. And so obviously, everything downstream is going to start getting ischemic, right? So loss of blood flow, loss of oxygen to it, and eventually it leads to its death, those cells in the muscle tissue. We can also get the narrowing of the blood vessels, right? The fatty buildup and everything inside. It can occlude the blood from flowing by. And so, people can have, the vast majority of their coronary artery blocked. It's not uncommon. I've got a couple of videos to show you guys where people have 99% blockages of their coronary arteries, and you can see that almost no blood whatsoever is getting through there. So that kind of thing, because of the blockages or aneurysms, they can prevent, obviously, any heart tissue downstream from where that blockage is or where that aneurysm is from not getting the oxygen and nutrients that it needs. And obviously that leads to the cell death, and then muscle death, and then the organ death, right? And patient death. So those fatty buildups, right? We get those fatty buildups in there. Let's see if I can just draw one real quick for you, right? So we got, let's see, we got our blood vessel right there. And then let's say this guy right here. Boom. All right. So this fatty buildup here, this blue thing, FB, fatty buildup, right? Obviously, it's blocking a lot of the artery here. So here's our blood flow. It's got to go up and around this, but not as much can get by, right? That's like what, 3/4 of the way occluded or blocked there. So that buildup right there is called a thrombus. That's what it's called, a thrombus. It's formation of a clot on platelets can get stuck there and form a clot. There can be diseased arteries, coronary arteries. The surface on them on the inside becomes really rough, and so platelets can start getting stuck to that, form a clot. And then it can break loose and start flowing downstream. And so if it breaks loose, when it's still attached, it's called a thrombus. When it breaks loose, it's called an embolism. Emboli, they can move to occlude blood flow downstream in smaller arteries in other parts of the body. So it can break off somewhere in the heart, get sent to the lungs, maybe block blood flow in the lungs, or maybe it gets pumped up into the brain and blocks blood flow up there. That would result in a stroke. So the blocking of a coronary artery by a thrombus, right, that fatty buildup there, or a clot, or an embolism, a piece of that stuff that's broken off and floated downstream. Blocking of the blood flow because of one of those reasons is an acute myocardial infarction, an AMI. You'll often hear it referred to as just as an MI. Both are correct, and both mean the same thing, heart attack. All right, here you go. You can see an example of cross section. So on the outside of the heart there, right? This is going to be mostly left ventricle here. We can see where the area of the cells that are not getting oxygen. And then if you look at the cross section there, we also we're seeing how much of that muscle it can be affected. So if this is the left ventricle, look how much of that muscle area. It doesn't look so bad on the other side over here, right? I mean, that's a pretty big area, but look all the way in through here. And so you think that heart, that ventricle, that left ventricle is going to be able to pump as efficiently as it should be to be able to get that oxygen downstream to all the cells in the body? It's not. It's just not going to be able to do that. So hopefully this is a good representation of what the problems can be, how much can be affected, how much muscle of the heart can be affected. All right. So acute myocardial infarction, it can cause ischemia. Again, ischemia is the loss of blood flow. It's reduced blood flow, so reduced perfusion to myocardium. And that leads to either injury of the cell because they haven't been getting enough oxygen for too long, or the cell death. They just haven't been getting any oxygen at all. Now, remember, each of the heart muscle cells has the ability to conduct electricity, and they pass along that signal as well. And they do it in a really nice and highly organized manner, which results in the nice, efficient, smooth pumping of that heart. Well, if you start having cells die around because of this ischemia, then they're not going to be able to pass that signal on to the next cell beyond them. And if that's the case, then all of a sudden we start getting dysrhythmias, right? These arrhythmias, these bad heart rhythms. So we have changes in rate, in the rhythm, and the ability just to pump the blood, right? So it's a cascading effect. We're having less of ability to squeeze because these cells are dying, and then when they do die, that cell can't help squeeze, and it can't help pass along the electrical signal. And so as things start going bad, the more cells that die, the more we have this cascading effect going on. Because of the electrical problems there and the mechanical problems, right? Electrical problems, we know, right? It's generating and passing along that electrical signal throughout the heart there. But those electrical problems result in mechanical problems, the actual squeezing and beating of the heart. And so if the heart is not beating really well and efficiently to get the blood downstream to the rest of the body, it can result in shock. And if we think back to when we first dipped in our toes into shock, that shock pool there a little bit, we have cardiogenic shock. Cardiogenic, right? Cardio means heart. Genic comes from Genesis, origin. So the origin of the shock is the heart, because it's not able to pump the blood down to the rest of the body. And so those cells throughout the body, they start going into anaerobic respiration, right? Where we're trying to make energy without enough oxygen. So it produces very little energy, but a lot of waste products. Cells end up dying. When our cells die, organs start to fail and die, and the new patient obviously dies. And one of the symptoms of some heart attacks, especially, I mentioned it earlier, that widowmaker, where the left anterior descending artery that is on the outside of the heart and supplies mostly the left ventricle with blood. One of the main symptoms of that is sudden death. So bad first sign, right? Well, it's not as bad as you think. I mean, it's bad. They die, right? But it's death within 2 hours of the onset of symptoms. So yeah, that's pretty quick still, but maybe not as long as or maybe longer than you thought it might be there. So sudden death, which is, again, it's your patient dying 2 hours after the start of the symptoms there. So it's not just, I mean, it can be, but it's not just like, oh, chest pain, and they drop over, right? It's not just that. That can happen, but more often than not, it's experiencing symptoms, and then within the next 2 hours, the patient dies. All right, so how do we treat this? Well, we talked about our treatment, right? Oxygen if we need to, ventilation if we need to, aspirin, and then nitroglycerin if it's indicated. At the hospital, what they're going to do is they've got a couple of options. There's fibrinolytics, which is basically administering clot-busting drugs. These drugs dissolve clots. They break them up inside the body, and so hopefully getting that drug on board breaks up the clot and then allows blood to flow again through those coronary arteries. There's another treatment that's called balloon angioplasty. It's where they basically stick a wire through either your femoral artery in your leg or through your radial artery in your arm. I believe going through the femoral artery is more common there, but they do both. And what they do is they stick this wire all the way up to the heart there, and then they send along that wire. Basically, it's a stint. Basically, think of it as like a mesh or kind of like a chicken wire kind of cylinder, and on the inside of it is a balloon. So they blow up the balloon, like they expand it, and that cylinder opens up with it, and then it stays there in the artery, keeping that blockage open. It kind of crushes it down, opens things up there. So it's like a cylinder kind of made of mesh, and like a metal mesh, and the balloon opens it up and allows whatever that blocked artery there to allow blood flow through that. What's crazy about the angioplasty is that people can be going into the hospital with massive blockages. I mean, percentages that are insanely high, like 75% of the left anterior descending artery 90% of it, 99% of it blocked. And if they get to treatment fast enough, after the onset of symptoms, they might be walking out a couple of days later of the hospital. Right? This is a far cry from the days where they do open heart surgery, where they have to basically saw open your rib cage, right? They saw through your sternum, they use rib spreaders to crack open your ribs, and then they go in and do this. That takes a long time to recover from. But with balloon angioplasty, small incision in your leg down by your groin, they feed all that stuff up there. People are walking out a couple of days later after this. There's a triumph of science. What this is, it's spectacular. And when we watch some of these videos in class, you guys will see what they can do with this angioplasty. Usually, what they get afterwards for treatment is taking. The treatment is they get aspirin every day, so they're on a low dose of a blood thinner, basically every day. All right, they'll also get a beta blocker. Beta blockers are something that you're going to become familiar with because they do two things basically that help patients with cardiac history. One, they lower blood pressure. And so this is going to help the patient that's had an MI because the heart, with the blood pressure lowered, the heart is not going to have to work as hard. And so it's going to kind of give it a break, especially this is really good if somebody's had a large area that is infarcted, right? So we have a large area that's affected because of the heart attack. This is going to make it easier for the heart to operate because the pressures are lower. Beta blockers also help with arrhythmias. Okay, so it helps to keep the heart in a good rhythm. We see, hopefully, we can see that if we've got heart cells dying that in the myocardium, that it's going to affect the electrical conduction system, and that can lead to dysrhythmias. And so beta blockers not only help with keeping blood pressure lower, but it helps to keep the heart in a good rhythm as well. Now, it's not just heart attack patients that will get these. And there are certain dysrhythmias or arrhythmias that people can have, and they'll be given both of these actually. So somebody can be diagnosed with atrial fibrillation, and they'll get the aspirin. It's an irregular rhythm in the atria of the heart that originates up there, and so they'll get the aspirin to prevent clotting because the atria aren't pumping correctly, and then they'll get the beta blocker to keep them out of that rhythm, to hopefully keep them out of that rhythm more often than not. So you'll see beta blockers out there. A very common one is called metoprolol. You'll see that one out there a lot. All right, assessment and treatment. Primary and secondary assessment, same kind of thing that we were talking about with ACS, acute coronary syndrome. Any of these symptoms that we're seeing, we're assuming that this, and so our treatment is going to be very, very, very similar. And so our assessment is going to be exactly the same. We're going to complete our primary assessment, taking care of any life threats that we may find there. And we're going to start our detective work, our OPQRST, figure out what's going on today. Back that detective up work with some more questions and sample to get a history of their past history, especially as it's relating to their condition today. So it's all going to be the same, the primary and secondary assessment there, and how we get our information and paint this picture for ourselves so we can get a full view of what's going on. And then our symptoms that we're going to see are very similar to ACS. We get the chest discomfort, we get the radiation, and that discomfort can be pain, discomfort, pressure, squeezing, all that kind of thing. We can get dyspnea, the trouble breathing, the nausea, the vomiting, the syncopal episodes, sweating. All of that stuff that we're familiar with from ACS, they can be experiencing. But our best treatment is to get them to the hospital, right? the treatments that we give them are taking care of symptoms, basically. It's not taking care of the root cause of the problem. The root cause of the problem can only really be taken care of in most cases by getting on an operating table, getting in the cath lab, so they can do the angioplasty, things like that. Right. So we're going to be handling symptoms there, and luckily, some of our treatments, like the nitroglycerin, not only does it provide relief, but it's actually doing some good there by reducing workload and allowing more blood flow, that kind of thing. It doesn't fix the problem in and of itself. So the definitive treatment at the hospital is getting them there for that is our best treatment. So get them to the hospital. These are load and go patients. We'll do what we can on the way. We're going to get 12 leads for all of these patients. Now, obviously, this is an ALS thing too. They're going to be able to do a little bit more than we can with this kind of stuff. Like just for example, the EKGs. Not only can they get the 12 lead done, they can interpret it there as well. They have the training to do that. With these folks, we got to be prepared for cardiac arrest, so it might not hurt to have the pads out and ready to get hooked up for resuscitation, or even placed on the patient as well. Aspirin, nitroglycerin, as usual, there for the treatment. All right, let's talk about heart failure and acute pulmonary edema. All right, heart failure and acute pulmonary edema. Luckily, we've already talked about this in the respiratory chapter there. So heart failure, it's often called CHF, congestive heart failure. What the deal is that the heart is unable to pump blood efficiently out to the rest of the body. And so as a result of myocardial infarction, heart disease, other things, it's most common with having an MI, right? The myocardium has been damaged or has died, and so the body, the blood can't be pumped around to the body efficiently, and so that results in a lack of perfusion to the body and cells there. So oftentimes we get those trouble breathing calls for patients with CHF. If the body's not getting perfused, they feel like they're short of breath, and it's because of the heart there. Anything that gets the heart going, pumping really hard, are difficult. It's tough. And now, when we say exercise-related tasks, somebody with pretty severe CHF, it might not be like, it's really hard for me to take a jog. Oh, well, yeah, that would be hard. But some of these patients are like, it's really hard for me to get out of my chair. They'll be out of breath from that, or going up a flight of stairs. So it's anything with the heart has to work harder. It's not necessarily, it's really hard for me to hit the gym and pump these days. It's not just that. It's anything that is causing, depending on the damage to their heart, it's anything that's causing the heart to work harder. So I had family members that had it, and my particular family member had it poorly. She had a really tough time getting out of bed or getting out of like her lazy boy without feeling really out of breath. And it was because of this. Because we have problems with the heart, right, and its ability to pump, the body has a much tougher time in compensating. We've talked all year about how the body compensates for lack of oxygen or other things, right? It's always trying to find that Goldilocks zone to stay alive. Things are just right. And so when there is a challenge to the body and it needs to compensate, it has a much harder time doing it now because of the heart failure. Now, congestive heart failure causes fluid backup. So this is what happens. We've talked about this before, how the pressure builds up. Pressure ends up building up all the way through down to the capillaries, and the capillaries leak out these extra fluids, right? Now, this is what happens if we have right-sided failure. So let's say, for example, your patient has had a heart attack in the past, and it has affected the right ventricle, right? The main part of the right side of the heart that's pumping the blood out to the lungs. So the pressure builds up in the right atrium, right? Starts backing up, start getting this traffic jam, right? And in the superior and inferior vena cava, right? So that's where the blood's coming from. It's not being able to be pumped out well this way, and so blood's coming this way, but the traffic jam starts building up because we can't pump out very well. So the pressure starts building up in the inferior and superior vena cava. This leads to jugular vein distension, right? Our jugular veins dump right into our superior vena cava. So when the traffic jam starts backing up, we're going to start seeing these jugular veins become distended. And then that pressure goes all the way from the veins, all the way down to the venules into the capillaries. And when the pressure gets high enough in those capillaries, it starts pushing that water and fluids out, not the blood, but water and fluids out of there. And then we get the edema, the swelling. So we can get it in the abdomen, and eventually it makes its way down to being pedal edema, right? Those capillaries all over are experiencing a buildup in that pressure, and so we're leaking out more fluids. Gravity eventually takes a hold of those fluids and drags them down to the gravity-dependent parts of our body. So basically our legs, everything below the knees. There we can also get it in the arms, around the wrists, hands there as well. But the pedal edema is where we see it mostly. So when we get the right-sided failure, that's where we're going to, that's where we'll start seeing the edema there. Now, can it get to the lungs? Oh yeah, definitely. Eventually the whole system's backing up and not doing great, but so we can get some pulmonary edema there as well. Now, the left-sided failure, though, this is if a patient has had, let's say, a myocardial infarction within the left ventricle. So we have myocardium there that is damaged or has died because of the heart attack, and so the left ventricle isn't being able to efficiently pump out to the body. So things start to back up. We get that traffic jam again, right? The left atrium starts to build up there. The pressure starts to build up in the pulmonary veins, right? From the lungs to the heart starts to build up there. And then once it gets to the lungs, then the venules and then the capillaries start filling up with that fluid, or the pressure starts building up in the venules and capillaries. Once it's high enough in the capillaries, it pushes that fluid into the alveoli. Remember, in the lungs, the alveoli are just surrounded. Those grape cluster-like structures are just surrounded with capillaries. So that fluid leaks directly into the alveoli. And then all of a sudden, you've got pulmonary edema. So that results in poor gas exchange. You can hear it, one of those rails, right? That fine fluid that the air is bubbling and crackling through. And you can get somebody really filled up, their lungs really filled up with this stuff. They're basically, if they get filled up enough, they're drowning in their own fluids there. And it absolutely can be a life-threatening situation. So left-sided failure, it's going to result in pulmonary edema first, before we start to see it going other places, like pedal edema. Right-sided failure is going to lead to pedal edema and swelling first before we start seeing it get back to the pulmonary edema. But we can have both from either side of the systems. The systems get backed up there. So assessment for this, we'll find out that they have a history of heart failure. We'll get that in our sample questions. They're going to have medications designed to control fluid levels, so like salt pills, things like that. It helps them to eliminate fluids, right? They're going to be on diuretics, things that help them pee more to get things out of there, to help control their fluid levels. They're holding on to too much fluid, right? It's in their lungs, it's in their legs, it's in the rest of the body, their abdomen, right? And we want to get rid of that fluid, and so we're going to take medications designed to do that there. So we'll see the pedal edema. We can see some swelling in the abdomen and buttocks, especially if, with patients that who are bedridden, or so your nursing home patients that maybe not able to get out of bed too much. So we'll see a lot of that sacral edema there, so swelling from the abdomen and things there. We can look, ask about, we'll see the JVD, right? We'll see that real nicely. And you can ask about like sudden weight gain, things like that, because all of a sudden they're holding on to all this fluid. Like, yeah, my pants don't fit me after the last couple of days. Once I started having problems, my pants don't fit me so good. Maybe they're swollen. Maybe they're swollen. They're holding on to all this extra fluid. So that could be a sign there as well. So we'll check for pulmonary edema by auscultating lung sounds. You may hear rails. They could be in all fields, maybe there with this. So they can get really full of that fluid. You'll hear the rails, the crackles when we're going there. People are going to have difficulty breathing. They'll have dyspnea. They'll feel short of breath. They'll probably have low oxygen sats as well. And then they can cough up this fluid. They're going to try to get it out. One of the ways they can get it out is by coughing it out, right? Like if you ever had a chest cold or anything like that, like bronchitis, where there's an overproduction of mucus, our body coughs it out, right? We cough to get it out. And so when people are coughing this up, this fluid, it's called sputum. And it's really frothy. It's because the air has been moving through it in the lungs, going through the alveoli, causing those popping and the crackling sound, right? Those are producing little tiny bubbles. So the spit looks really, really frothy, right? And it could be pink. If there's a little bit of a pink tinge to it, that means there's a little bit of blood in it as well, which may not be unusual for these patients. So our primary assessment here, we may have to do for the patient with congestive heart failure, pulmonary edema, we may have to ventilate these patients. And we may have to decide in our ABCs, in our primary assessment, that maybe CPAP is the right treatment here, or at the very least, BVMing, to try to force air down into those alveoli there. So we know what the indications for that are, right? So very shallow breathing, really poor tidal volume, poor work of breathing, right? We're not getting an expansion of the chest. Breathing rates that are either really high outside of the normal range or really low outside of the normal range as well. We'll use OPQRST to get history of the present illness and sample to dig into do our detective work in their past medical history. And then we'll get the EKG done. We'll listen to lung sounds. We're going to be checking their skin, feeling their pulse, keeping track of vital signs like blood pressure and heart rate there as well. Treatment for these guys, we're going to treat the signs and symptoms. We're not going to be able to, fix the big problem. And so we're going to treat the signs and symptoms. A lot of it is trouble breathing. So we'll focus on that. So a lot of it could be the positive pressure ventilation. If we have a patient that's real full, the lungs are real full, then we should get ALS there. We can get, they can do things that we can't. For example, we can set up the CPAP as EMTs. We can't run it, ALS can give nitroglycerin for these folks, and that helps to reduce the pressure. And so it's in the cardiovascular system, and so the body's not pushing out those fluids as much, and so that can really help them. So, but those are ALS skills. So if we're seeing somebody with this trouble breathing, we're suspecting that it's CHF, they have a history of it, things like that, get ALS there, especially if there's really any kind of distress whatsoever with that. All right, let's talk about the last little bit here. The last thing that we're going to talk about is aneurysms. Aneurysms are obviously problems. What it is it's a weakened section of an artery wall, and it's weak because of genetics, heart disease, things like that. It can weaken, and that wall of the artery balloons out, right? It balloons out there. Instead of being, a nice little compact artery, there's a weakened section that balloons out. And those weakened sections can burst. And so if that aneurysm, which is that ballooning there of the artery, bursts, then obviously that can be a life-threatening condition because that blood that was flowing through there is now not getting downstream to where it needs to be. It's spilling out of this burst pipeline, right? So that can obviously be life-threatening. Here's a little example. So you can see the ballooning of the artery here up at the top, and then later it bursts. Now, obviously these can be life threats, cardiac conditions, but this can be one of the reasons somebody has a stroke as well. A lot of times, folks with aneurysms, you're going to see blood pressure issues. A lot of times they can be hypertensive, so keep an eye out for that. One of the real problems for us with aneurysms is that obviously we can't get to this bleeding. We can't stop this bleeding. I can't put pressure on this bleed. I can't stop it. It's inside the body somewhere. And so depending on which blood vessel has burst, where it is, what is it feeding, right? Is it feeding like the left ventricle? Is it feeding an important part of the brain, something like that? Depending on the size and the location of that blood vessel, the results can obviously be catastrophic. They can kill your patient there. So our treatment for anything like this is going to be rapid transport and support. And so we'll maintain an eye on their SpO2 and their oxygen levels, how their breathing is, things like that. But really, our transport is the best option for these folks, getting them to definitive care, because we can't stop this bleed in the ambulance. There's nothing I can do. I can't tourniquet an aneurysm of a coronary artery. Can't do it. So for these, they can be rapid and they can be life-threatening. There now, a patient may be aware that they have this. They absolutely may be aware if they have this. Now, this is going to have them having gone to their doctor before, having had regular checkups and types of tests and things that can determine this. And so we may be able to get a history out of this, and so we can get to the hospital and let them know exactly what's going on. So there may be a history here that we can find out about. Some of the signs and symptoms of some of these are it's like a tearing pain, or like it's in the head, like a very sharp, like painful headache. There is a type of aneurysm of the aorta in the abdomen. It's called an abdominal aortic aneurysm, AAA. It's your aorta going through down through your abdomen there, and that can have an aneurysm and then eventually burst. And the common symptom with one of those, which is like immediately life-threatening. Most people don't survive AAAs, abdominal aortic aneurysms. But one of the common signs of that is a severe, like, tearing pain, like 10 out of 10 on the pain scale, and it's like a severe tearing in the abdomen. So usually aneurysms, they produce sharp pains, like a lot of pain depending on where they are. And one of the common ones for one of the bigger aneurysms, most deadly aneurysms, the AAA, there is a severe tearing sensation inside the body. All right, that'll do it for the end of our chapter there. So if you have any questions, shoot me an email. Make sure you watch this and then read up through the book. We'll be hitting on some more details when we go over this in class. All right, guys, we will see you next time.